السلام عليكم ورحمة الله وبركاته. This is Ahmed Damanhouri, lecturer of cardiology. Today we'll discuss together one of the common causes of non-ischemic chest pain, which is pericarditis. At first, what is the pericardium? Pericardium is a fibroelastic sac which composed of two layers, visceral serous layer and the parietal fibrous layer. Both layers are separated by potentially cavity which contains 10 to 50 milliliter of straw-colored fluid, and the function of the pericardium to protect the heart and reduce friction between the heart and surrounding organs. What is the definition of pericarditis? Pericarditis is inflammation of pericardial sac, and if it is associated with inflammation of myocardium, it is called perimyocarditis, and it represents about 5% of ER visits for non-ischemic chest pain. We classify the pericarditis according to time course: acute, incessant, and chronic. In acute pericarditis, it is a sudden, less than 3 weeks. Incessant pericarditis lasts about 4 to 6 weeks, but not more than 3 months. But chronic pericarditis develops slowly and lasts longer than 3 months. What is the cause of pericarditis? Number 1, infections. Like viral infection, it is the commonest cause of pericarditis, bacterial and TB. Or malignancy, metastatic disease like lymphoma, melanoma, or direct extension from lung carcinoma and breast carcinoma, or primary cardiac melanoma, which is a rare disease. Inflammatory, and it is common, post-myocardial infection, which is called Dressler syndrome, uremia, collagen disease, and post-cardiac surgery. Lastly, intracardiac pericardial communication like blunt or penetrating chest trauma, post-catheter procedure like EP study or electrophysiological studies, percutaneous coronary intervention, valvuloplasty, LV rupture post-myocardial infarction. So, what is the pathogenesis of pericarditis? Like any inflammation in the body, there is three steps for inflammation, with vasodilatation and transduction of fluid, increased vascular permeability and leakage of protein, and after that leukocyte exudation with neutrophil and mononuclear cells. Clinical presentation of pericarditis or perimyocarditis. The most common symptoms is chest pain, which anterior chest wall, sharp, pleuritic in nature, radiate to both or one of trapezius muscles, increased with cough, inspiration, swallowing, lying supine, decreased with leaning forward, sitting, holding respiration if it is associated with pleurisy. In presence of pericardial effusion without tamponading, the chest pain decreased or may disappear. There is another general symptoms like low-grade fever and difficult breathing. What about the examination of the patient? The pathognomic feature of the pericarditis is presence of pericardial rub, which present in 85% of the patient. Where we heard it, what the character of pericardial rub, what the components of pericardial rub. The best heard with diaphragm at lower sternal border with patient leaning forward, and it's characterized to be scratching or grating sound, and it has three components corresponding to atrial systole, ventricular systole, and early diastole. During AF, we lost atrial systole, so the pericardial rub has only two components. With the presence of pericardial effusion, without tamponading, the pericardia disappear and the heart sound become distant and the apical impulse not visible or palpable. This is about the physical examination of the patient. What about investigation or how to investigate the patient? First of all is the ECG, most important diagnostic clues to differentiate between ischemic and non-ischemic chest pain. In pericarditis, we have 4 stages for ECG changes. First few days up to 2 weeks, widespread ST segment elevation, upward and concave, except in AVR and V1, with PR depression, which is very characteristic for pericarditis. Stage 2, last days to weeks, ST returns to baseline with flat T wave. Stage 3, after 2 to 3 weeks, last several weeks, T wave inversion, and lastly, up to several months, gradual resolution of T wave changes. With perimyocarditis, there is many atrial or ventricular arrhythmias can appear. Here, ECG changes showing PR depression and concave, upward concave segment elevation widespread in ECG. This is another ECG which showing acute myocardial infarction with ECG changes. You can notice the S segment elevation is convex upward without PR depression. The next step after ECG is echo. Echo may be not diagnostic in early stages of dry pericarditis, but we should do it to rule out other structural heart disease causing pain like MI, aortic dissection, or pulmonary embolism. But with development of pericardial effusion, we assess the pericardial effusion and rule out tamponading. So we did ECG, echo for the patient, and lab tests. Inflammatory markers should be done early, like ESR, CRP, leukocytosis, other tests like autoimmune disease like lupus, rheumatoid arthritis, which may be the cause of pericarditis, elevated cardiac troponin or cardiac enzyme, which suggests myopericarditis, kidney function to rule out uremia. After diagnosis of pericarditis, what's the prognosis of pericarditis? As we said before, most common cause of pericarditis is idiopathic or viral pericarditis, which have a good long-term prognosis. The cardiac tamponade rarely occur in the patient with acute idiopathic pericarditis or post-viral pericarditis, but with a specific underlying etiology like malignancy, tuberculosis, purulent pericarditis. It depends on the cause. Lastly, what's the treatment of pericarditis? We aim to, in treatment in pericarditis, to relieve pain and treat the underlying cause and prevent cardiac tamponading and constrictive pericarditis. The first choice is non-steroidal drugs like aspirin, acetyl salicylic acid, or ibuprofen. Number 2, steroids. If there is no response for non-steroidal after 2 days, and we use it with non-steroidal. Number 3 is colchicine, which is very useful and the first choice to treat chronic and recurrent pericarditis with or without non-steroidal. And don't forget treatment of the cause, whatever the cause. Lastly, thank you very much. Good luck.